Now we're going to switch gears to the data that I'm going to present, which is the data for Pirtobrutinib, formerly LOXO-305, a next-generation highly selective non-covalent BTK inhibitor in previously treated CLL. These are updated results from the phase 1/2 BRUIN study. So these are my disclosures. Okay, so this is the BRUIN trial, and it was a phase 1/2 study which was conducted in patients with chronic lymphocytic leukemia and B-cell lymphomas. I'm going to just talk about the CLL patients today. Martin is going to talk about the patients with mantle cell lymphoma who participated in the trial. As a little bit of a background, the current space in CLL, in the current space of CLL, we're using covalent BTK inhibitors like ibrutinib. They're very active drugs, but we do see a lot of discontinuations due to adverse events or due to resistance. And so there is a major unmet growing need where we need new novel targeted therapies for managing patients with CLL who've been through drugs like ibrutinib or Acala or those drugs plus venetoclax. And so this drug, Pirtobrutinib, was designed to be a non-covalent inhibitor of BTKI, and because of its design, it had the theoretical possibility of overcoming the CYS481 mutations, but also working in wild-type non-mutated CLL, and also highly specific for its target, meaning not a lot of off-target effects, and therefore could be quite well tolerated as well. So an ideal molecule in terms of its design with a lofty goal to meet an unmet need for patients with CLL. So phase 1/2 study, as stated, eligibility included patients with CLL or B-cell lymphoma. They had to be previously treated. They had to have a decent performance status, and they had to have progression of disease and in need of therapy. The study endpoints included safety and tolerability, determination of the MTD and recommended phase 2 dose, PK data, efficacy data in terms of overall response rate, duration of response, and of course, patients with CLL were measured by traditional response criteria by the IWCLL. Okay, so this is the breakdown of patients who participated in the trial at this time. Again, phase 1 trial was where we looked at doses between 25 and 300 milligram. Ultimately, it was decided that 200 milligram was the go-forward dose for phase 2. And a total of 618 patients have been enrolled on the BRUIN study as of this time. Pretty large phase 1/2 trial. Of those, 296 patients had CLL or SLL. And then of those, 252 patients had been previously treated with a covalent BTK inhibitor. So the focus of the most recent update to this trial was to look at the subset of patients, the 252, who had been treated with a drug like ibrutinib or acalabrutinib, really to get a sense of efficacy of LOXO-305 or Pirtobrutinib in this particular situation. These are the characteristics of the patients who participated in the trial. Median age, you can see there, was 69. This is a heavily pretreated patient population, 3 prior therapies as a median, but a range up to 11. And then you can see that the population really represents a real-world population. Everybody had a covalent BTK inhibitor. Nearly everybody had an anti-CD20 antibody or chemotherapy. 41% had a BCL2 inhibitor. 20% of patients had a PI3K inhibitor. Even 6% had CAR-T. And you can see that the most common reason for discontinuation of the prior covalent BTK inhibitor was actually progression of disease. And then in terms of the risk profile, I would consider this to be a pretty high-risk patient population based on the molecular and genetic profile. 43% had a CYS481 mutation. Even 16% had a PLC gamma 2 mutation. 28% a deletion 17p. 37% a TP53 mutation. And 84% were unmutated for IGHV. So in terms of population, about as heavily pretreated and high risk as you can get. Now I'll share the efficacy data that we have available. And so what you can see here is the overall response rate in the 252 patients who previously had a covalent BTK inhibitor was 68%. Those responses improved over time. And so for the 119 patients who had more than 12 months of follow-up, it increased to 73%. Again, keep in mind, not shown here, but there was also a waterfall plot that almost all patients with CLL who received a covalent BTKI showed a marked tumor reduction. So nearly every patient had a significant decrease in tumor volume when they were treated with Pirtobrutinib. This observation was regardless of the reason for discontinuation. So, for example, if you were intolerant or resistant to ibrutinib, the drug still worked very similarly. And then responses were consistent in all analyzed groups, meaning that whether you had long-term follow-up or short-term follow-up or a CYS481 mutation or not, or even a PLC gamma-2 mutation, no difference in response. Number of prior therapies didn't affect response. For example, in the double exposed patients, or even in patients who had 5 prior therapies, including all of the modern classes like a PI3K inhibitor, BTK inhibitor, venetoclax, chemo, CD20, response rates were consistent. And of course, there haven't been a lot of discontinuations thus far. About 75% of patients are still on drug. And so we expect with further follow-up that the response rate will continue to deepen over time. Here we have data on survival outcomes, and here we see progression-free survival. There's 2 different Kaplan-Meier curves here. The left is the entire patient population, and you can see from this, I think, most notably that responses were durable to pirtobrutinib. This is all of the patients who were previously treated with a covalent BTK inhibitor. Median follow-up is now increased from the last time we presented this data to 9.4 months, and the median progression-free survival has not been reached. On the right, there's the more heavily pretreated patient population. This represents patients who had at least a covalent BTK inhibitor and a BCL2 inhibitor, but truthfully, a lot more than that. The median number of prior therapies was 5. And with that being said, with the same follow-up, the median progression-free survival was 18 months. And as stated before, 74% of patients remain on pirtobrutinib at this time of this population. Now we'll delve into the safety data, and here you can see the adverse event table. Now this includes all 618 patients who've been treated with pirtobrutinib. Couple things I want to highlight. Number one, there were only 4 adverse events that occurred at a rate of greater than or equal to 15% across the board. That's all grade, all causality, and those were fatigue, diarrhea, neutropenia, and contusion. And if you look at the AE table, these are relatively all low-grade events. Of course, when we're dealing with BTK inhibitors, we're always interested in those events of special interest, like, for example, atrial fibrillation or bleeding or bruising, so on and so forth, the ones that have really been most notable for the covalent BTK inhibitors. These events were relatively, or I would say extremely rare on pirtobrutinib, but particularly if you look in the columns for grade 3, 4, high-grade events really didn't occur. And we're always measuring activity, or rather adverse event profiles for BTK inhibitors based on the AFib, A-flutter rate, and that was 2% overall. There was no DLT, MTD was not reached. Most patients had been treated with the phase 2 recommended dose of 200 milligrams daily. And overall, the discontinuation rate here due to an adverse event was only 1%. So to me, that's really a great measure of how well tolerated the drug was. So in conclusion, pirtobrutinib has shown promising efficacy in CLL and SLL patients previously treated with a BTK inhibitor and many other prior therapies. The overall response rate that we reported here was 68%. Currently, several ongoing phase 3 trials are evaluating pirtobrutinib, both in the frontline and relapse refractory setting as monotherapy, as well as in combination with Ven-R in the relapse refractory setting as a time-limited therapy.